Yeah, that's good. You're halfway there.
I'll talk about that. Okay. Good morning, everybody.
Good morning.
I'm Tom Scott, president of TCAS Seniors, and we've got a great meeting set up for today. Hopefully you got yourself a little breakfast. Just to talk a little bit about what's happening as we're live. This gets recorded and it's out there on YouTube. And there's a lot of information that you can go back and see. Or if you've got seniors out there that can't make it to these meetings, they can go on and watch this meeting. Okay, which is fantastic. This is my teleprompter. We may get one. I saw one, you know, you can get them. They're pretty nice. Okay, so we're going to go around the room. I want everybody to introduce themselves and where you're from and so on and so forth. Okay, and the doctor that's going to be talking is going to be up pretty soon,
Yeah.
right?
Yeah.
Okay.
I'm Dr. Kennedy. I'm originally from Gainesville, Florida. Orthopedic surgeon, obviously. So.
All right.
Christine, Elder Home Care Services and board member.
Mary Scott, Great Scott Group, Keller Williams, and board member.
Caitlin Obard with South Florida Orthopedics and Sports Medicine.
Amanda Martin with HCA St. Lucie and Longwood Hospitals.
Pat Miles, Harbor Place, Senior Living.
Tricia John, Lake Forest Park, Senior Living.
We're going this way. Tanya Campbell, Parks Home Health Care.
Stacia Rigo, also Parks and Healthcare.
John Daly with Senior Care Authority, Senior Defined Homes and Retirement Community Living.
George Huff, attorney, elder law attorney, and a board member.
Matt Baxter with State Safety Services, also a board member.
Jennifer Ross, Council on Aging of St. Lucie and board member. And why don't you introduce yourself?
Oh, yeah.
Oh, hi. Hi, everyone. My name is Nicole Vaughn. I'm with Fishshire Senior Living, Assisted Living and Memory Care Community.
Bill White, the president, and we, Mike and I are neuroscientists down from Rhode Island, and we own a company and are launching a company called Prime Brain, Body, and Mind, 55ers plus. I know no one's over 55 in this room, but so we're excited to be here. Thanks.
Catherine White, CEO of Prime Brain, Body, and Mind, 55 plus. It's great to be.
Libby Wiseman, Luxury Homes of the Treasure Coast, Senior Transition Navigator.
Hi, I'm Michelle Butler. I am an author, grief coach, speaker, and I also work with Libby helping seniors transition. Very well, Molly's off.
Mark White, Dice Care Services.
Good morning, Stacey Weeks with Encompass Healthcare.
Hello, Brian Leach with Encompass.
Good morning, Jeff Schatzel with Senior Helpers.
Good morning, Sean Murphy with Northwestern Mutual.
Good morning, my name is John Dalton. I'm the owner of Optimum RTS, which is your full-service medical employment agency and home care sales trainer.
Hello, Peter Brandis, Stewart.
Diana Martin Stewart. Renee Gooder. I'm the service coordinator working with seniors in Washington, D.C.
Morning, Steve Gold with White Glove Moving Storage Delivery Service.
I'm Michelle Doherty with Home Instead Home Care Services.
Hi, I'm Diane Lee.
I'm a certified nurse care manager.
Hello, good morning. My name is Andrea Davis with Panda Touch Caregivers and a Patient's Choice Home and also board member.
We aren't. Why is she standing? She's going to talk about the fantastic hour that we had 2 years in a row.
I just want to tell everyone inside here how grateful and thankful I am. Appreciate all your help that you offered us to raise $7,500.
Nice.
And that goes to our seniors who need help. Right away, we had someone that we had to offer help to, about $700 or something we had to pay.
$995 for Medicaid.
So it comes right in hand for that. So we want, looking forward next year for all your help. Bring your friends and family. And it's gonna be at the same place. I'll announce the name of that event, the time. And we are grateful. Thank you so much.
Okay, so, yes,
You didn't
you
introduce
didn't
yourself.
talk about yourself.
Sure,
This is-
absolutely.
Good morning, my name is Alex Foreman with Techie Expert Web Design and more, and as the name implies, yes, I do web design, but I do so much more. I do graphic design, email and back-end automation, your Google business profile, which I don't know if you know this, if people can search 3 or more words out of your business name, it's guaranteed that you will appear pretty much front and center, right on the top without needing Google Ads. And of course, that's gonna provide all of the information about your hours, your location, reviews, images. I can help increase your online presence, increase your sales, and automate your workflow so you can spend more time doing what you do best. Thank you.
Again, this is live, so we're out to the world. We've got some new equipment that we purchased in the last few days to help. So you'll see that we have split screens now. And last time we had a situation where we had basically a power surge, and I get them at home too. And so we only got about 25% of the meeting, but then we had to restart it. So it was a nightmare. So now, we have that all set. So, and we do a lot of work behind the scenes, and Alec does with myself to make sure that we keep upgrading the systems that we have. Okay, so George, so we want to talk about voting today?
Yeah, but I thought we'd do it after the meeting. You want me to do it now?
Well, do we want to talk about it and then pass them out to the members and then they can do it and then hand them in on the way up? How would you like to do it?
I'll do whatever you want. I'm easy. I'm an attorney, but I'm easy.
Okay, so what's going on with our voting, right? George is going to talk about it and explain the rules, the regs. Yearly, we have to do this. It's normally done in October, but as you know, we had hurricanes and all kinds of crazy stuff going on, right?
Yeah, we're gonna vote here today after the meeting. You don't have to get too excited. You have to be a member to vote. And basically, we have a board of directors, and we're dividing it as per the bylaws into 1 year and 2 year terms. And then thereafter, that's just for this time. Thereafter, it's every 2 years, so that only half the board comes off at any one annual election. So there's continuity, and then there's, within the the rules, we've got then Christine is the vice president, but she's really also president in waiting or president-elect next, whatever. And Tom's, loving to get off the board. Tom works so hard.
I'll stay on the board, but.
Yeah, he works so hard, it's unbelievable, but in that kind of time. And, really we appreciate it, we don't say it often enough. But so really all you're gonna do is you're gonna mark on here those you want to be on board. Don't take one if you're not a member of the association. If you are, you have the right to vote. And if you want, you can write in names. And if somebody wants to be secretary, write your name in here. We'd love to have you on the board. So I'll just pass this out, and then I guess as you're leaving, just turn your ballots in, and we'll announce later. I'm assuming it's going to be, approved. If somebody wants on the board that bad, call me. We'll get you on the board. All right, I'll pass out. Let me just do it.
Okay.
We continue.
All right. Okay, so Catherine is off on a trip on vacation, having the time of her life, right? I'm sort of happy for her, no? Well, I am, okay. So anyway, she normally talks about the history, and this group started in 2008. So I cheated this morning. I got up about 4 o'clock and cheated and put the history that's on our website, and I put it on our Facebook site. And of course, you can also see it if you go into our system and our website. You can see the history information there too. So I won't bore you by going through 5 or 10 minutes of all that history. You can go see it on your phones. All right? So again, it started 2008 and Catherine was part of it and she has done so much all these years. So how long has that been?
Math is not, well, yeah, math is my forte, but.
So 17 years, something like that. I think it's going on 17 years or something like that, this group. And then now you see what it is. You know, we've got boating on, we've had hurricanes, we've had tornadoes. And, you know, we've had all this crazy stuff and we have, I think, a fantastic group here today. So again, with some of your people and your clients and whatever, just let them know about this and they can see some of this. I mean, the speaker today is going to be phenomenal. I'm going to talk about it. And we have great speakers. Right now, we're set up about halfway through next year already with speakers. So, you know, people want to get involved with Treasure Coast Advocate Seniors and get to these meetings and get their message out. So we're real excited about that. So you can also join if you're not joined. Go to our website. You can pay right on there. And also, we're going to start by talking about, stay on my teleprompter here, the bio of Daryl Candidate. Oh, we can't start there yet. You know why? I almost always forget this. We need, first, Jeff Schitzel up here. We need him up here. Come on up. I almost forgot last time. You know why? Because I didn't have anything to eat yet. I don't remember. So tell us a little bit about yourself, and we thank you for the breakfast this morning, coffee.
Okay, well, good morning, everybody. Happy Thursday. It's my pleasure to be the coffee sponsor this time. I know I missed it a couple months ago, but dual scheduling. So I am with Senior Helpers, and we are a private duty home health agency in the area. We specialize in a couple different areas of senior care, memory support and Parkinson's. What that means is basically we train the caregivers additionally above and beyond what they normally go to school or get their certifications for in memory support, different levels of Alzheimer's and how to approach that patient and approach that family in caring for their loved one. So we take those attributes and diagnoses from the clients, and we make sure that the caregivers are going in firsthand knowledge on how to help that individual. And the same with Parkinson's support. There's a lot of different ailments that a Parkinson patient may exhibit and may have. So the additional training on how to position, how to maneuver, how to assist that client goes a long ways. We are an agency, so we are certified under ACA, and we are also Joint Commission, which is above and beyond what ACA standards are supposed to be. So we have 140-ish franchises around the country. I believe one in Australia, and they're modeled around the basis of everyday in-home care, but that's basically what you get. So anyway, thanks for listening and have a great day.
Thank you. Yeah. And help yourself anytime you want to go up. So, our doctor today, Daryl F. Candidate, right? Number two, right?
Yeah.
There's a first?
Yes, there is.
Okay. Is a board certified orthopedic surgeon with fellowship training in adult reconstructive hip and knee replacement. I'm gonna talk to you because my right knee is like a little sore, you know? He earned his medical degree from the University of Miami Miller School of Medicine. His orthopedic residency training was completed at Orlando Health. Lastly, he completed his fellowship training at the University of California, Los Angeles, which won the World Series last night.
Oh, wow.
Yes, and how about that, huh? How about that, huh? I grew up there, so I grew up there until I was about 13. It was awesome. So, and I have a lot of friends that are New York Yankees fans, so they're not talking to me today. So, Dr. Kennedy has substantial training in both operative and non-operative orthopedic care. The doctor's practice is primarily composed of partial and total knee arthroplasty, with the use of technology and manual techniques. Anterior, posterior, total hip, arthroplasty, revision hip, and knee arthroplasty. Trauma, including operator treatment of peristaltic,
Periprosthetic.
okay, fractures. Interesting. So without any further ado, come on up,
All right.
Dr. Kennedy.
Good morning, everybody. My name is Dr. Kennedy. Just want to reintroduce myself. I'm board certified orthopedic surgeon, and that I can do anything orthopedic surgery, but my specialization is in hip and knee reconstruction. I am currently in my third year at Southport Orthopedics, and I primarily operate at HCA St. Lucie Medical Center, Cleveland Clinic South, as well as several ambulatory care centers as well. This is just kind of an overview. Again, I was born and raised in Gainesville, Florida. Went to stay there for college and then had to get out of Gainesville for a little bit. So I left and went to a big city, went to Miami, then Orlando, and then went all the way to LA because it was gonna be the last chance to get out of Florida. And then I ended up coming back to Florida. Again, these are the procedures that I primarily do: primary total hip arthroplasty, anterior and posterior approaches. We'll go over that in a little bit. I do partial and total knee replacements. I do revision knee and hip replacement as well. This is when the hip or knee arthroplasty has failed, whether it's infection, loosening, whether it's fractured. I go back in there to fix it, and then you're on your way. I also work on trauma, and I also do knee arthroscopy. So arthroplasty is a surgical treatment of arthritis. So it is, so arthritis is defined as the degenerative changes within the joint, leading to joint destruction, leading to significant pain. The three most common types of arthritis are osteoarthritis, which is the most common, which is what we see, wear and tear, long period of time. Some people develop in their 30s, some people develop in their 80s. There's post-traumatic arthritis, which is where you have an injury, which then causes you to develop arthritis at a later date. And there's autoimmune arthritis, so your rheumatoid, your Sjogren's disease, your lupus patients that develop arthritis in their joint because of their disease. So this is just an example of somebody with post-traumatic arthritis. As you can see here on his right hip, so this is his right hip because it's my right hip right here. He did have a previous fracture. It did go on to arthritis as well. I will be converting this to a total hip arthroplasty in a couple of weeks, actually. So when are you ready for surgery? This is when you have significant pain. Remember, we do not treat x-rays. There are patients that have very severe arthritis noted on x-ray that have no pain. You do not do a knee or hip replacement for these patients. You only do it when you have pain, and more pain. So the pain interferes with your daily activities. You've tried to control pain with oral medications. You've tried injections. You've tried therapy. You've tried all these things, and your pain is just unrelenting. A lot of patients have pain that wakes them up at night as well. That is when we start discussing whether or not to proceed with surgical treatment at that point. So starting with the hip, there's multiple ways to access the hip. You'll hear people talk about the anterior approach, posterior approach, the lateral approach, superior approach. I primarily do the anterior and posterior approach. I do the lateral approach for certain patients, only in certain situations. There's really no difference in the outcomes for any of them. The anterior approach is the newer, more common, a little bit easier to recover from because the precautions are a little bit easier to abide by. With the posterior approach, which is a classic approach, the utilitarian approach, you have to abide by certain precautions where you can't bend 90 degrees, you can't turn your leg inwards. Some of it's like normal activities or normal movements of your leg that you have to avoid to prevent any dislocation. With the anterior approach, because we're not disrupting those structures in the back, you can almost do normal activities at that point. The only things that you can't do are like yoga poses, which is like the warrior pose that we don't want you to do for the first 6 to 8 weeks usually. And the lateral approach is another classic approach. Very easy approach. I use that for my hip fractures in patients that have to do a partial hip replacement. So that's my low demand patients that I use it for. So these are where the incisions are. So anterior, so this is the front, and then this is the back right here. So this is where we make our anterior approach. This is the lateral approach. And this is the posterior approach here. More than 90 or even say 95% of my practice at this point are anterior approach. I'm very adept at this. I will do the posterior hip approach as necessary. So discussion with the patient depends on different comorbidities, depends on the ability for me to access the hip. But I do try and do anterior as much as I can, but if I have to do posterior, I will do a posterior hip as well. Patients do well in general. It's probably one of the most successful surgeries in the last 100 years. And I think it was like Time Magazine was classified as the surgery of the century. 99% satisfaction rate. Patients do very well. They don't necessarily even need therapy after surgery. I do recommend it, but as long as you get up and start walking, you'll heal very well. Hips do very well, very, very well. I have several patients that walked out of the hospital the same day, no pain. The only pain they felt was from the incision. I have other patients that are a little bit slower to recover, but everybody's different. And that's why I say recovering from surgery is not a sprint, it's a marathon. So you have to take it step by step. So everybody's different at this point.
Thanks.
So this is one of the poses I don't want you to do within the first 6 weeks. Right here. I do use X-ray imaging during hip arthroplasty. This is to help with placing my components, make sure I place in the proper position. Especially with the anterior approach, that allows me to use X-ray a lot easier because you were laying on your back during the surgery. Whereas with the posterior approach, I have to actually push you on your side. A little bit hard to get X-ray. I can get the X-ray during the surgery, but this is why I prefer anterior approach as well. So this is how we position the patients. This is the top, at top left, we have the HANA table. This is what I use for my anterior approach. So once you go to, you won't remember being put on the table. We put you to sleep before we do this. But I can take your leg in whatever position I want to. I put it in positions that you don't necessarily ever get into, but that is to make sure that your hip is stable and to prevent dislocation as much as possible. And then this is the posterior approach right here. So this is where you put you on the side with pegs to hold you in place, and I can do my surgery this way as well. So what is the total hip made of? It's a titanium alloy. This is an example of one of the stems that I commonly use right now. There's a plastic liner inside of the cup as well. It's a medical grade plastics. The old plastics lasted maybe 10 to 15 years. We're at highly cross-linked polyethylene. We're expecting 20, maybe 30 years out of these plastics. The wear rate is so low that most people, once they get it, barring no other complications, they'll pretty much, pass away with this hip and it look perfect. Next slide. Keep going. And another stem that I use, and this is kind of harder to see, but there's a cup, and then we put a liner, and then there's a ball that goes on top of the stem there as well. And so this is kind of a schematic. So this on the left, we see this is kind of a schematic of what arthritis would look like. So you can see that the cartilage has actually worn away. It's very red, it's angry, it doesn't like us, very painful. So what I do is actually make a femoral neck cut with a saw from Home Depot. No, I'm kidding. Make a cut with a sterile saw, remove that bone. I then use what's called a reamer. It's a grinder. So it actually grinds the bone and grinds the arthritis away inside the cup. And that allows this cup to actually stick in there. I always put screws in there. It makes me feel better. It gives a little bit of reinforcement. We don't necessarily need the screws, but I do put the cup in there, put a couple screws, put the plastic liner. I then use broaching, which is like a chisel. Open up the inside of your bone until this stem is big enough, and then I stick it in there and it fits on there. Your bone actually grows onto the stem and actually grows onto the cup. Because of the nature of the metal, it's very gritty to allow the bone to actually encase itself in there. These are some examples of arthritis. These are previous patients I've done. So you can see right here, bone and bone arthritis. There's no space here. On this hip, you can see there's a little bit of space. I mean, they're starting to develop arthritis, but this is severe arthritis right here. And this patient had bilateral, bone and bone articulation as well. And these are some examples of previous patients that I actually recently done. They're doing excellent. I'm going to do his other hip pretty soon. And this patient's doing well. The left hip does not hurt. This is actually a 92-year-old patient that I did about 8 weeks ago. I actually just saw her the other day. She's been living with this hip for, I want to say the last 10 years. She's been having hip pain. Nobody really wanted to do her surgery because they said she was too old. I said, you're not too old. I mean, she's walking on her walker, barely getting around the walker, has to use a wheelchair. Did anterior hip. Because of the bone quality, I did cement this hip, put a cable for reinforcement to make sure her bone doesn't break. She's up and walking with just a cane at this point. She's doing very well. Great. Any questions about hip arthroplasty, or I can save the questions today and I can finish my presentation as well. I was going to finish the presentation. So We're gonna start with knee arthroplasty. So there's three main compartments of the knee. So there's the medial, the lateral, and the patellofemoral compartment. The medial is the inside, lateral is the outside, patellofemoral is behind your kneecap. So all of these compartments can develop arthritis. Most commonly what we see is we see a lot of people develop arthritis on the inside of the knee. Some people do develop arthritis on the outside of the knee in combination with this or in isolation. If you only have arthritis in one of your compartments, there is a chance I will be able to do a partial knee replacement. I actually did one yesterday. The patient's doing well. She went home. She's doing my call this morning. She's doing great. So in order for me to do a partial knee replacement, for anybody to do a partial knee replacement, you have to ensure that there is no arthritis in the other compartments, that it is completely clear disease. I get MRIs, and I also look there when I'm in surgery to make sure I don't see any arthritis, and I will do a partial knee replacement. It is not a very common surgery. It's very tedious surgery, so really only people that have done these a lot or they're trained to actually do these surgeries. Otherwise, most people will do a total knee replacement, which is completely acceptable as well. So that's where you do arthroplasty of both the medial and lateral compartments, plus or minus the patellofemoral joint as well. So the goals of surgery is to cut out the arthritis, decrease the pain, have a stable knee, and restore proper mechanical alignment as well. So these are examples. These are pretty much primary components that I use. This is one of the partial knee replacements that I use right here. So you can see it's very small. It only goes on one side of the knee, so a single compartment. These two are total knee replacements. Difference between these two, these are the same component, same company. This one is cemented into your bone. This one is not cemented into your bone. This one actually just came out, I think, last year. So I've been using this a lot for patients that have very good bones. So my younger patients that are in their 40s, 50s, or 60s that have very good bone, I actually just stick this in there, and just like the total hip arthroplasty, your bone actually grows into these great surfaces. Otherwise, if I have any concern, this is a standard treatment, which is where we put the components cemented in place. Both work very well. This is a patient that I did last year. She's actually over a year out doing excellent XR. I think in July, she was a year and a half. So she had isolated arthritis on the inside of her knee right here. She had preserved space. I also confirmed this with an MRI that she had no arthritis on the lateral or behind her kneecap as well. And I looked during surgery, so I elected to proceed with the partial knee replacement. So you can see I only resurfaced this side of the knee, which is the inside of the knee. The great thing about partial knee replacements, and which is different from total knee replacements, is that I preserved all your ligaments, your ACL, your PCL, your LCL, MCL, everything stays in place. It's literally resurfacing where I only cut the bone and I cement in the metal components and put in the plastic components here. And then next slide. This is a patient that had severe arthritis. As you can see, bone on bone, you have arthritis behind the kneecap on the inside and on the outside as well. And as you can see here, the total knee replacement. The difference between doing the partial and total knee replacement is that we remove your ligaments. Some people only remove the ACL, some people remove both the ACL and PCL. I remove both the ACL and PCL to do the surgery. I feel that I get a better balance with that and get a more stable construct as well. And this is an example of a press fit prosthesis, which does not have cement as well. So this is some of the technology I use. This is the ROSA robot, which is available at both at HCA St. Lucie Medical Center as well as Cleveland Clinic South and one of our new surgical centers as well. It is a surgical assistant. It assists me doing surgery. It does not do your surgery. It helps me make measurements. It does not do your surgery. You don't want a robot doing your surgery. So that's pretty much what I use it for. I actually attach trackers to your knee. You can track it in space. I can make adjustments to it, and then if I don't like what the robot's saying, I can do what I know, which is a lot more than a robot, and make those adjustments for you and fine tune it. These are some other technologies I use. I use OrthoLine. It's a handheld size of your iPhone. I can actually attach this to your knee, make the same measurements, track it in space as well. And then this is the new Corey robot, which can do both primary and revision knee arthroplasty, which I'm actually getting trained on. So I'm getting certified on multiple aspects of technology, like different technology from different companies as well. So commonly asked questions, do I use a robot unit or any other technology? Yes, I do. I just showed you the ROSA and the other technologies that I use. Again, the robot does not do the surgery. I do the surgery. It just helps me to measurement. It's another data point for me. Does the robot take longer? Not necessarily. Sometimes it takes a little bit longer, a couple minutes with the setup, but otherwise it's pretty negligible in my practice at this point. How successful? Success is measured, per patient. So in general, total hips and total knees do an excellent job. Hips typically do a lot better than knees. Knees are hard to recover from than hips. Hips, you just get up and walk, you're feeling pretty good. Knees, there's a very strict and very painful recovery process. I require pretty much everybody to go through some kind of physical therapy with their knees because getting that flexion extension is paramount at that point. And yeah, or I should go back. Oh, sorry. No, you're good. How long do the implants last? We're hoping that we can get these implants to last 20, 25, 30 years for the rest of your life at this point. The materials have gotten so much better. The biggest thing that's changed is the improvement in the plastic. The old plastics, they used to wear down a lot, which leaked what we call free radicals. So it's bad molecules that get out into the bone and soft tissue, which causes losing the implant, which will require you to have a revision. So you come see me, I have to revise at that point. So we try not to do that as much. Like I said earlier, hopefully new plastic, we can get at least 20, 25, or even 30 years out of these. So a lot of people come into my practice and they're like, oh, I heard you only do revisions. I don't only do revisions, I do revisions and primary. So primary is the first surgery, the revision is the redo. So a revision specialist is somebody that knows how to redo a hip or knee replacement or even whatever other replacement that you have in your body in order to fix it and give you a stable implant as well. So there's aseptic loosening. So that means loosening of the implant without infection. There's infection as well. You get bacteria in your knee or your hip, you have to go back to surgery. There's no treatment where it's just PO antibiotics and we just give you antibiotics that clears. Once you have infection in your joint, you have to have surgery at that point. Fracture, so I go in there. If I have to, sometimes I have to take the implant out, put a new implant in there and a plate to fix it. Sometimes I can just put a plate on there. Dislocation and instability. So you hear about people's hips popping out. We have to put them back in the ER. Once that happens more than 2 to 3 times, you pretty much have to have surgery and have the hip redone and stabilized as well. These are just some examples. So as you can see here, the implants are a lot bigger. This was a patient I did for aseptic loosening about 4 weeks ago. So her knee was completely loose. It literally just popped out once I carved it out of the bone. I try to preserve as much bone as possible, and I put stems and a lot more cement into the implants in order to keep it stable. And then this is a patient that came on my trauma call. She had a total knee done about 20 years ago. She fell, broke her femur, has a distal femur fracture, and her implant was completely loose. So I actually had to redo everything. Excellent. So I actually had to cut out the total knee replacement, put a longer stem, and actually do what's called a distal femoral replacement. So stem up into the femur, pretty much had to cut the distal aspect of the femur, attach the hinge, and so she can get up and function at this point. And is that it? Yeah, I think so. One more. So this is another patient that I did. She actually, a younger patient, had her hip done about 15 years ago. Unfortunately, there was a recalled implant, was searching for a surgeon to redo it, but then she kept having dislocations. And then next. So she had dislocation, fell, actually broke acetabulum. Somebody put a screw there. I had the screw removed. And as you can see, the cup has actually changed. You see here, the cup is in a relatively appropriate position, and the screw actually knocked the cup because the cup was loose and actually moved. So she continued to have dislocations for about 4 to 5 years. She had been living with this. So she had to come to me, and I had to redo the entire implant where I took everything out, put a longer stem, increased her offset, put a new cup in there, screws, and she's doing great. And then keep going. Yeah. This is another patient who had a lot of medical comorbidities, had an intertrug fracture, fixed it. However, because he was on chronic steroids, he was unable to heal the bone after a year. The nail is only there to stabilize the fracture still has to heal. Because it never healed, the implant gave out. These implants can't break. So the implant ended up breaking, and I ended up taking it out and doing a revision arthroplasty. He's doing excellent right now. He's about 4 months out. So this is my business card. So there's a favorite business card over here, or you can scan the QR code. It pulls up an online business card with my Instagram and ways to contact my office as well. So I'll just leave this up here for now. And does anybody have any questions? Yes.
Doctor, so when does a patient know a timeline when they think, they need to see you and or have surgery? Is there a threshold?
To initially come see me, anytime you have any kind of knee or hip pain, come see me. We can get an x-ray, I can work you up. We can always see if you have arthritis or if you just have what's called a meniscus tear or anything, if we need to order MRI. Painful total joints, if you had a knee done, last year, a couple years ago, and it just starts aching and having a lot of pain, come in and see me. We'll take an x-ray, I'll see what's going on because I have to work you up. So anytime you pretty much have any kind of knee or hip pain, I'm happy to see you in clinic. We'll get an x-ray, check and see what's going on, and then we'll treat you as such. Yes.
Post-surgery protocol for follow-up care when you're dealing with hips and knees. In the past 10, 15 years ago, there was a heavy call for home care. We were doing the physical therapy in the home. How quickly are you trying to move somebody from home care to outpatient therapy? And also, is there a need for private home care companies that are doing non-skilled services, help with ADLs, getting in and out of the tub, bathing, dressing, et cetera, et cetera?
Yeah, so initially, for most of my patients, we have them in home health care for anywhere between 2 and 6 weeks. And then we transition to outpatient therapy. Everybody's different. People have different social situations. Some people can't get to the physical therapist office quickly or within the first couple of weeks without help. So they'll be in home care, healthcare a little bit longer. Some patients are able to get to outpatient therapy a little bit quicker. So some patients will go straight to outpatient therapy. They don't want to do home health care. So it's really different. As far as rehab centers, those are usually reserved for either sicker patients or people that don't have help at home at all. We get them over to a rehab center like Encompass, which is one of the hardest ones to actually get into because they do a great job over there. That's pretty much how we do it. But getting up and moving, it's pretty much immediately. I always prescribe, if we're doing the hospital, physical therapy and occupational therapy in the hospital. So they work on doing normal ADLs as well as walking. There's a fake Corvette that they teach you how to get in and out of. There's stairs, they take you on stairs, they take you around walking. So really depends on protocols. All my primaries, I want them up and moving as quickly as possible, honestly. So, yeah. Yeah.
You mentioned that when you do the knees, that sometimes it's partial and sometimes it's total, and that it's based on x-rays and symptoms and what you see when you open them up and stuff like that.
Yeah.
Is there ever a time or is there ever like a risk factor that would make you be more inclined to go ahead and do a total, even if there's only an indication for a partial? And my other question is, if you disconnect the ligaments, don't we need those?
Okay, yeah, so to answer the first part of your question, we take the x-rays, we take the MRI, nothing's perfect. That's why I go in there and directly look at the other side. If I have a partial, I will plan for a partial knee replacement. I always have the total knee replacement on backup. I look on the other side and see if I see any kind of arthritis that may have been missed on the x-ray or may have been missed on the MRI. As long as that's clear, I do proceed with partial knee replacement. If it's not, and I see something that caused me to hesitate, then I will do the total knee replacement at that point. And then what was your second question again?
Don't we need the ligaments that you just connect?
Oh, the ligaments. So no. So the ACL. So
I kind of thought those were important.
Yeah, they're important for a normal knee. There are people that are living without ACLs that have a normal knee as well. But there's pretty much 2 schools of thought for total knee arthroplasty. I mean, there's a third one, but nobody really does it. You either keep your PCL, which is cruciate retaining, or you get rid of your PCL, which is cruciate sacrificing.
What's cruciate again?
The posterior cruciate ligaments, that's the PCL.
So it's the one on the back?
Yeah, it's the one that attaches to the back. And then the anterior, the ACL is called the anterior cruciate ligaments. The reason why they call it cruciate is because they're across like this. The collaterals are the NCL and LCL. Those we definitely need for total knee replacement because those help with the coronal alignment. We always remove the ACL at that point. The PCL is really surgeon preference. If we remove the PCL, the way the implants are designed, they actually help to substitute for and account for the missing PCL. So if you do keep the PCL, then the certain plastic piece that is inserted is designed to keep the PCL there, to have the PCL accommodate for that. If we do remove it, then the plastic piece that you put in there has to account for the PCL being gone. I always remove the PCL. That's my preference. Some people don't do it. I worry about risk of the PCL actually being torn. So if it tears later on, then your knee becomes unstable because all you have is a cruciate retaining implant in there. now you have no PCL, so nothing stabilizes the implant becomes unstable. So I say, why not just get rid of it and then put in something that will stabilize both the ACL and PCL, so I have to think about that later on in life.
So the particular equipment that you put in replaces the joint and the ligaments that you're talking about?
Yeah, so it accommodates for it. So yeah, it replaces, so it's a joint replacement, so it's really resurfacing. So we're, getting rid of the arthritis, and the plastic piece accommodates for the biomechanics of having an ACL and PCL. There's no difference between whether somebody keeps your PCL or not. It's really surgeon preference. Like I said, I just prefer to remove both the ACL and PCL. I think most people are moving that direction, so. Yes.
Why are the outcomes so different from a procedure that's done from wear and tear compared to a sudden incident when there's break?
Because of the medical comorbidities for that patient, and when there is a fracture, that means there's something else going on metabolically. So people that just come in with arthritis, they're usually, pretty stable. They can have medical comorbidities, but when you fall and have a fracture, that means you might have osteoporosis, you might have some other medical comorbidities. There's damage to the surrounding structures. If you remember, once you break a bone, the bone's splintered. It's very, very sharp, and it could actually cut you. It can cut through gloves sometimes as well. So sometimes those fractures can cut through, small areas of muscle. So that's why it's more traumatic for that, rather than just a fracture. And then you had a question.
I'm just wondering about prevention, what we can do to prevent from having to have these surgeries in the first place.
So I always tell people that hip and knee replacements are not definitive, like they're elective surgeries at the end of the day. 150, 200 years ago, we never replaced people's hips because we didn't know to do it. It's really kind of patient preference. I have patients that come in every 3 to 6 months, sometimes once a year, just to get an injection. They're going about their merry way. I have patients that come in and they can't deal with the pain. They've tried everything and they just want the surgery at this point. It's really pain tolerance. Some people have higher pain tolerance than others. Some people come in, they know that I actually don't want surgery, I'm scared, or I'm not ready for surgery at this point. I just want the injection. It takes my pain down from a 10 or a 9 or whatever it is down to a 1 or 2. I can deal with a 1 or 2 because I can take Tylenol whenever I need to. Some people can't tolerate that pain, and it only takes them down from a 9 to a 7. So it's really person dependent. Again, these are elective procedures. I never really say you need a knee or hip replacement. The only people that really need hip replacements are when they fractured a bone. You pretty much have to have a hip replacement, based on the fracture pattern. But these are elective procedures. So I never rush anybody into having a procedure. I never tell them like, you need to have this done. But it's elective. So if you want to live with it and you can live with the pain, then that's fine. But if you can't live with the pain, that's when we start discussing surgery. Yeah.
On the medication side, what might your opinion be cortisone versus gels?
Cortisone versus gels. So cortisone, tried and true, evidence-based, it works. So it works for the most part. Gel injections, literature's kind of mixed reviews. Some say 50-50, some say 70-30. Some patients do very well. I usually only use gels in between. After I've given a steroid injection, I would give a steroid injection that's first line therapy. That's AOS guidelines as well. Gel injections is kind of up in the air. I say, look, we can try the gel injections if you're not ready for surgery or you don't want surgery. There's almost a 50-50 shot that it'll work. Some people, it works great. I have people that come in every 6 months, get the gel injection. They're like, this works amazing for me. Other people, you give them a shot, doesn't work at all. The other injections you have are PRP, which you've probably heard of, platelet-rich plasma, where you take your blood, spin it down, you re-inject it. Less evidence for that, not necessarily covered by insurance. I will do it. I haven't done it in my practice, but I don't push for it at all because I don't really say that. I can't guarantee that it works or have that much evidence. But again, it's patient dependent. People don't want surgery and they say, hey, I just want to at least try PRP. I say that, okay, that's fine. Stem cells is where I kind of draw the line for me. I won't ever do stem cells. There's no evidence to support it. It's extremely expensive. It's out of pocket. If stem cells work, I'd be doing that instead of surgery, honestly. So,
for hip replacement, you had mentioned use of that reinforcement device. Is that kind of unique to, or sort of unique to your practice, or how commonly do surgeons use that reinforcement?
The reinforcement device, what reinforcement device are you talking about?
For the hips, you had said you had, in one of your, you had You had-
Oh, I put screws in the cup? Is that what you're saying?
And then there was another, I think, even,
Oh.
something that you reinforced.
So, as far as reinforcing the cup, I mean, that's surgeon preference as well. Some people, there's no difference between whether you put screws or not. That's been proven in the literature. I put the screws in there just because, like I said, I think it just helps reinforce, gives it additional area of fixation. It works well in my practice. It takes me about 20 seconds to do. Some physicians don't put screws at all, and that's completely fine as well. The big thing is that the bone is growing onto the back of the cup. That's what supports it right there. The screws are just there to, give it a little bit more fixation. Yeah.
So many really elderly folk oftentimes have these like bone fractures in the leg, upstream from a replacement. And I think you had mentioned that you did something to help
Prevent it, like a cable. Yeah.
Yeah, is that common, or is that something that you're just kind of?
I'm always thinking ahead. So like I said, that patient was 92 years old. Pretty much anybody over 80 years old, I'm very careful when I'm doing any kind of surgery for everybody, I'm very careful, especially for greater than 80 years old. Your bone density issues go a lot lower at that point, increased risk of fracture. Once I get in there, if I feel that your bone is mushy, which sometimes it is, like you can just put your finger in there. I've been into people's hips and knees where I can take my finger and actually push it in like, Swiss cheese. That's when I'm thinking, okay, I need to put something in here, a cable to reinforce it before I put it down there as well.
It just seems to make, a lot of sense, PRM anyway.
Yeah, exactly. And then for that patient, like I said, I was really worried about her bone, so that's why I cemented it. The cement acts as a reinforcement, so it's pretty much like, cementing a building. So you put barbed wire or, bar, and you put cement in there to reinforce it as well. So, yeah, extra precautions.
I know, right? Well, we're saying exercise. So what is that bone prevention so our bones don't turn into Swiss cheese? What vitamins should we be taking?
Exercise, calcium, vitamin D, magnesium, take a multivitamin. Once you get over a certain age, certain guidelines to check your bone density. Some people will develop osteoporosis just because of genetics, but really, exercising is gonna be your best bet. Exercise and vitamins, so. Remember, calcium, vitamin D, and magnesium, they all help with the absorption to help keep your bones strong as
So
well.
just take your vitamins then.
Yeah. Some people, they have lower bone mineral density. That depends on the DEXA scan that's ordered from your PCP, and they'll put you on certain medications that can either help prevent further breakdown, and there are some agents that are coming out that actually help to actually regenerate your bone and make it stronger as well. Yeah.
We talk about lifestyle improvements that help all around, and exercise is key.
Yeah.
But do you talk about prevention from the standpoint of avoiding inflammation so that over time, less weak bones, less arthritis, et cetera, back to the point of what can we do to prevent this?
I tell people, everybody's gonna die with some kind of arthritis eventually. It's gonna happen. It's a wear and tear disease. Ways to prevent, the progression or, slow it down sometimes is keeping your weight under control. Typically what's seen in research, heavier patients develop arthritis a lot quicker. Keeping your muscles strong, quads, hamstring exercises, I give that pretty much to all. I have a, pamphlet that I give to my patients that are not ready for surgery so they can do quad hamstring exercises. Some people want to go to physical therapy to get stronger, learn some exercise as well. Exercise is going to be your best friend. Really, it's really pain control. So how much can you tolerate the pain? Because eventually, people are going to develop arthritis. Some people may never develop arthritis or develop very mild arthritis, but it really depends on how you can, how much you can control that pain.
Is it true if you do vigorous exercise like on the treadmill?
Yeah.
You can put up a restraint on your knee, like wear and tear?
Yeah, that is true. Typically, we see that in runners that are running on concrete because it's not forgiving. Treadmill's a little bit more forgiving. People that have, arthritis are in a lot of pain, but they still want to exercise. Sometimes they do activity modifications. That's whether it's swimming, biking, hiking, walking. All these are low impact activities. But staying strong is, the big thing. But some people, like I said, running on concrete is just not forgiving at all. There's a lot of force going down to running on concrete. Yeah.
With the rehab side of things, what criteria do you use to decide when prescribing weight bearing restrictions, like with your periprosthetic fractures?
So that's sometimes, a lot of times like an intraoperative decision. If I'm not nervous about their bone quality or anything, I will go straight to pretty much weight-bearing color. I try to get people with weight-bearing color as quickly as possible. The more that you weight-bear and put weight on your bones, that allows the bone to grow back. It's Wolff's Law. So Wolff's Law, once bone is resisted and cause resistant, it builds itself back up. So the quicker you can get back to weight-bearing tolerated, you can get that bone to actually improve. If I'm concerned about any kind of stability of the bone, if I do an extensive procedure that requires a lot of fixation, a lot of cables, a lot of plate, I will limit their weight bearing for a temporary period of time, look for any bony healing and follow up x-rays, make sure that I see that bony callus forming, and then I start advancing their weight bearing as well.
My last question.
Yeah.
The difference between doing the decision to do a hip resurface as opposed to a replacement. My buddy just had a hip resurface.
Yeah.
Obviously it's different, but why would you pick one over the other?
So I don't do hip resurfacings. Hip resurfacings are, relatively rare procedure that's done across the country at this point. They were done a little bit more often a few years ago. You'll find somebody do it. Hip replacements work great, so I don't see the benefit of doing a hip resurfacing, honestly. There are some hip resurfacers that have to go get that converted to a total hip replacement, a little bit more complicated procedure. So it really depends on your surgeon, but I don't see the point in doing a hip resurfacing if a hip replacement works great, because they both do pretty much the same thing at that point. So, but it really depends on the surgeon. So.
He was led to believe that he can go right back to athletics once a heal.
Yeah, you can go back
to having a replacement.
Yeah, you can go back to athletics after your hip is healed too, a hip replacement. So yeah, I have several patients going back to pickleball. I've had a patient run a marathon last year actually. So yeah, several patients go back to. It really depends on, it's patient dependent, but really there's no difference in the true outcomes of like a hip resurfacing. If you have a surgeon that does great hip resurfacing, great, have the hip resurfacing done as long as you meet the criteria for hip resurfacing. Otherwise, have a hip replacement, pretty much the same thing.
Any other questions? We all set? Okay, well, thank you very much, Doctor.
Thank you.
Pleasure. Thank you. Okay, so. Surgery. So very quickly. Right, doctor?
He's going to the
Okay, very quickly, we're just about done. November 14th, we had to postpone and move forward our September meeting because of the weather. It was bad, very bad that day. So we postponed that meeting in September, and it's moving to November 14th. And we'll be here probably in the big room. The election will be over, and we'll be able to get to that. Also, make a note, December 5th, we're having our holiday party. We're gonna have a blast. All right? Okay. We also have a few things to give away. All right? And does everybody have their card in the basket?
Here.
There you go. Okay, like that. There's another one. Okay.
First one is, please don't say that she.
Say it out loud, Christine.
Say it. And this is from Michelle Butler, real estate agent, and that is going to Nicole.
There you go.
And
You can say it, Nicole, it's okay.
we say it all day long after that. Broken Roads, Dr. Sarah, and that is, I'm assuming, a bunch of Halloween stuff.
It's been
Goodies, Patty.
It's not
Mimi, wow.
There you go.
White Glove Moving and Storage.
There you go.
What is it? What is this? This is a quarterly shirt? Where did he go? This is is it a quarterly shirt? Or, I know, a bottle of wine and some goodies, and that is going to Dr. Sarah.
Great Scott Group, we got a bottle of wine, he guarantees it wasn't sitting in the car, and it's not me. Good, and that's going to Libby, where's Libby?
Okay, just a reminder, members, please fasten your voting sheets, right?
Anybody want the doctor's information? It's up here.
Have you had a home surgery before? I have.
Other than it's our next meeting, you said, right?
I had the same.
Thank you all. Have a great day.
I had a short hair.
Oh, thank you.
It's just- it's- yeah, well, I don't-